Right, the recording of the session of the webinar has started. And as usual, if anyone needs to tell us anything about being aware that they are on a recording, they do need to let us know. But so this is a really exciting experience for everybody. It's great to have a recording that you can keep going back to, isn't it? So it's just 1 minute past. People are still coming in. Marie, are you okay to wait another minute or so?
Yeah, I
Thank
think
you.
so, yeah, because it's only just 4, isn't it?
It is, yeah. They're really visually very friendly, your slides, Marie, aren't they? They're lovely.
Do you think? I like
I
to have
do.
the visual alongside because it gets a
Yeah.
bit boring if it's too much text, doesn't it?
Oh, yeah. So you would have seen Mary was on when we first came on, Marie.
Yeah.
You may know Mary from our education circles.
Hello. Sorry, when I first joined, I was struggling to get my microphone on.
Oh,
but...
you got it now, Mary.
Hello, Marie.
Hi, Mary. Nice to meet you.
Likewise.
Okay.
I'll turn my camera off.
2 minutes past now. So, welcome and a warm welcome to the ABPN webinar, Association of British Paediatric Nurses webinar. We're delighted that you have joined us, and our very special guest speaker today is Dr. Marie Clancy. You can see her title on the slide there. And do you want to say a little bit, Marie, about yourself and how you would like this webinar to go? May I just say right at the beginning that some of the ABPN officers are on the call. We've got Fiona Smith, who's an ABPN fellow, and she is the officer who has arranged this webinar. So thank you, Fiona.
Yes,
and we've got Mary Nash, who is our ABPN membership officer designate. So we have got ABPN members as well, officers as well as members. So Fiona and I will keep an eye on the chat. And over to you now, Marie. Thank you so much.
Thank you so much, Jean, and thank you to Fiona for organising and inviting me to speak today. Welcome to everyone who's joined us. So my name is Marie Clancy. I'm a children's nurse by background. I've been qualified 25 years for my sins and have been in nurse education for about the last 15. I was just mentioning to Jean before we started properly that this has really become my life's work. Really all about creativity and arts-based approaches in children's nursing. I'm going to look at a range of different ways that I've applied this, and hopefully some of that will be useful to those of you on the call or those of you that are watching this back afterwards. I think what we mentioned is if you want to put questions in the chat as you think of them, because if you're like me, you might forget them otherwise, and then we'll address those at the end just so it doesn't stop the flow of things as we go along. But I know Jean and Fiona are there if you need anything, any other things, or if there's any technical issues, obviously just let them know in the chat as well. I won't be able to see that, but I know they'll stop me if they need to. So thank you so much for helping with that. So as you can see from my first slide, I'm an honorary senior lecturer at the University of Exeter. That's where I've been was working for the last 4 years, and I've stayed on an honorary capacity there to help with a PhD student who's about halfway through her PhD. and I'm also working as a visiting lecturer at the University of Plymouth at the moment. And I'll tell you some other developments about what I'm doing later in the course of the presentation. So I've got two nice pictures on these slides, and there is pictures throughout, as you can imagine, when the session is titled Creativity and Arts-Based Approaches. But I wanted to just highlight to you that the two are there that are quite separate. One, you'll notice, is very much distinctly done by children and extremely beautiful, I think, of nurses that have been looking after them. And the other is done by staff, and that is deliberate to say that, as I said previously, I'm going to talk about a range of approaches within this. It's not all for children or children actually doing the art. A lot of what I've done has actually been student nurses and staff doing art as well. So just to mention that straight away, really. So I'll start just with some aims, things that I hope you're going to get out of the session. You can correct me or pull me up on this if we've not managed it by the end. But what I wanted to do is just talk to you a bit about these creative approaches that I've used in children's nursing and why I think they're so important. I'm then going to give you some examples alongside some evidence, because obviously I'm an academic, so I'm not going to miss that bit out. About how, as children's nurses, we can use some of these approaches to help us to understand the complexity, which is our job, and the families we serve, how to problem solve some of the issues that we come into contact with. And also one of the main factors, I think, is about trying to understand children and young people's perspectives, give them more of a voice, and kind of remove some of those power imbalances and obstacles that are in our way sometimes to hearing what children have got to say about their health and about the services that we provide. There is another slight element to this, which is also about the historical perspectives, and that's some of the nurse education work I've been doing, so I'll come on to that as well. And I hope I'll be able to offer you some guidance about your clinical practice, about education, and about research, because I know many of you will do, if you're anything like me, a kind of a bit of a combination of those things. So hopefully this will be useful to you. So I'll start with the rationale. Arts-based approaches, when I use that phrase, what I'm meaning is things like art, music, storytelling, and poetry. Obviously, there's a massive range of things. I could list 100 things there, probably, of what would fall into arts-based approaches, but these are some of the big ones. And I think some of the main ways they've been used in children's nursing to date is to reduce anxiety, to manage pain, to promote coping, and improve communication. And it's trying to give children and families as well these non-verbal ways sometimes to express complex things. Often it's in a very stressful environment, such as hospital, or it actually might be that they're trying to take part in a research study to inform future practice. But actually it's quite intimidating to sit in an interview face to face, as you might do with an adult. So that's why these things can be useful to take away some of that difficulty that they might find in that situation. They've also been shown, these approaches, to help create a sense of normalcy and control for children and young people. And I mentioned before about the imbalances that we probably are all very aware of, that actually children are in quite a vulnerable position when they're receiving care from us, and they don't always feel empowered to be able to express how they feel, what's happening for them, or perhaps their needs at any given moment. So again, these techniques can hopefully help us with some of that. I really like this phrase of these techniques serving as doorways to help us understand children's experiences, make the experiences of healthcare more child-centred, engaging, and hopefully less intimidating for the children that we see. I also think that these approaches can help children's nurses develop their empathy and understanding of children's perspectives, and families too. And that is particularly important, I think, and again, I'll come on to some examples of this, where there are any differences between the children's nurse and the families that they're serving. So that might be things like different languages, different culture, different elements of personality even. We know that there are some families that it's super easy to get on with. You build a rapport very, very quickly without any effort at all, and it's wonderful when that happens. But there are other families where it's actually really hard work, and you think, is this me? Is it them? Is it a combination? And sometimes it can just be very simple differences in the way we speak or the way we interact, or even just in lifestyle. So I think arts-based approaches have a really valuable role in those situations. I actually started using poetry in an education context. I'd been writing poetry probably since I was about 9. But since I started my nursing, it was very much in a secret way. Probably none of my nursing colleagues, when I started my first clinical role in oncology, would have known that I was writing poetry at night or when I'd finished my shift. And I found personally that that was a real cathartic thing for me. And I realised that actually it could help my students. My first academic role was at the University of Wolverhampton when I was running a critical care module. They had a placement then that was centred in the neonatal intensive care unit, and they had to choose a case study to explore for their essay. And I realised that they were really struggling to empathise with the parents they were seeing there. And this wasn't because there was a lack of care. It wasn't because they didn't want to empathise. I think, again, it came down to that difference. Some of the student nurses were very young, they hadn't got their own children, and they really struggled to understand the complexity of loss some of these parents were facing after IVF, maybe multiple losses, huge amounts of miscarriage, obviously, in that population as well. And so we used poetry with the students, and there's a little article reference there, which is a little bit old now, but hopefully you can have a look at that and see, to try and get the students to see parents' perspectives, because they wrote poems about their experiences in that environment, and the students explored them together. And you'll see in that quote there that they felt that that was a really different way to explore parents' perspectives. And they found that actually each of them had a different interpretation of those poems, and they're able to explore them together and say, oh, why did that word mean that to you? Or why did you suddenly think of that? I didn't see that. And it was quite helpful. So again, just to emphasize to you that I think sometimes we ignore differences that maybe exist between us and the families we serve. But I actually think it's really important that we acknowledge those, acknowledge perhaps where we're a bit limited in our experience or understanding of certain things, and try and maybe fill some of those gaps with some different approaches to our communication and our ability to relate. I mentioned to you before about this cathartic nature of poetry. I think I started writing poetry when I started in oncology. I was working at Birmingham Children's Hospital at the time in the oncology, haematology and bone marrow transplant unit. And as you can imagine, I'm sure some of you have worked in similar environments. It was very stressful. It was very, very busy. We were seeing a lot of very unwell children and families. And obviously we were dealing with palliative care end of life as well. And what I found was that I struggled to tell anybody else about what was happening to me, apart from the friends I had in that environment. And I didn't want to burden my family. I didn't want to burden friends that weren't nurses. And so I started to write. I started to write about some of these families, and I felt a real release when I did. It was almost like the privilege of caring for them, of having that experience with them. I was able to contain it and put it somewhere, maybe not to share with anyone, and I definitely didn't for a long, long time, but to maybe put it to one side so that I could go to work the next day and carry on and have space in my head for the new children that I was looking after that day as well. So I don't know if any of you've got experience similar to that, or if you're interested in learning more about that, but that is something that I have written a little bit about. Another rationale is about the education of staff well-being. And I've got some more examples and more details of all those things to follow. So we'll go through some of those aspects and ways in which I think arts-based approaches can be helpful for all those different aspects. So I'll come first of all to some of the methods that I've used and try and talk to you about some of these. My PhD was actually about children's palliative care, and it was focusing on refugee and asylum seeker families. I was again working in the West Midlands at that time, and we would see refugee families coming into the palliative care service and really struggle to meet their needs. It was very obvious to us clinically that they had vast amounts of needs, that the service didn't really respond to those needs very well. Our knowledge base didn't really respond to those needs very well, and that families were really falling through some of those gaps that were created. So I thought actually this is something I could get really passionate about and investigate. I probably didn't realise at the time that I was probably choosing one of the hardest ethically complex things to research, both children's palliative care and migration. But actually, it's proved to be a really interesting amount of work. One of the main things that I had to think about very early in my PhD was advisory group, or patient and public involvement, somewhat some of you may know it as, mostly because as you can probably tell from hearing me speak, I haven't actually got experience of migration myself, and I was very aware of the limitations of my experience in that regard. So I very quickly developed my own advisory group in order to help inform me, so that I wasn't doing anything insensitive, culturally inappropriate, or trying to assert my knowledge over a community that were more than able to tell me about their experiences, and for me to share it where appropriate. You'll see this image here. When I first started doing my PhD, I realised that there was no images that really displayed what it was I was going to talk about. So I had a young person on my advisory group, and I had quite a big young people's advisory element to my PhD, and I'll come to some more of the work they did for me. But one of the first things she did was create this image for me. And you'll see it looked very pretty, I think, on the first picture there. But after speaking to some of the refugee and asylum seeker communities, they gave me some feedback and said, look, actually, maybe you need to represent a few more families than just one. Maybe you need to show not just someone in a bed. There's a few too many crosses there. That looks a bit religious. And some other feedback they gave me, so we're able to alter that. They really liked the fact, though, that those faces were blank, because it kind of showed to everybody that I didn't know what I was talking about, that this was me investigating and exploring. And so I think here an image actually told an awful lot about my study before I even began. It told the community I was listening, that I really wanted to hear what they had to say, and I was going to respond. As you can see from the two images, that there was a change in them. And also that I didn't know, and I did want to hear, and I did want to find out what those expressions were and what those experiences were as a result. So you can see how a simple image actually probably showed quite a bit, even just from that very beginning of this work. I used what many of you may know already about. It's been around for quite a long time. A draw and talk, or draw and tell, it's sometimes called, methodology. It's been linked to enhanced data collection because there is this idea that, as well as someone talking to you like in a normal interview, you're also going to get some extra data. You're going to get some extra data in terms of maybe images that you can investigate and say, oh, what did you mean by that? Or why did you colour it like that? Or why is it so big? Or why is it so small? Or lots of questions to get people to interpret what it is they've done. And it can also help people to kind of use different language, I think, when they've got something visual in front of them, rather than, as I mentioned before, just being put on the spot in an interview situation where they're fired a question, they have to think really quickly what the answer is. When you're asking someone to draw and talk at the same time, you actually give them quite a bit longer to think, to doodle, to really sort of digest what it is you're asking them before they respond. And then often what I did was have more than one interview where maybe we looked at those images separately and went through them and thought about what was happening when someone was writing them. The little image you can see on the left-hand side of the paper here is an example that I presented to one of the refugee groups to see how some of my questions might work. If they thought this community would be able to engage. The academic community actually was a bit reluctant for me to do this. They said, how are you going to use draw and talk? How are you going to use poetry with a community whose first language is very frequently not English? What I actually found was that it helped. And I'll come on to some of that. But actually, everyone was a little bit worried about me doing this, that it wasn't going to work, and that actually all I was going to find is that there were more barriers or limitations by actually trying to introduce some of these aspects. That isn't what I found, luckily. And the community were very, very happy to help me. They really wanted this project to take place because I think they realised that a lot of people were coming to the UK to seek medical treatment, and that wasn't always as well provided as it could be. And so they were really receptive to this, and they had quite a bit of fun answering some of these questions, drawing me some pictures, guiding me and educating me, and telling me how I could improve some of those things before I actually spoke to any participants, which again was really, really helpful for me. You'll see this image actually comes from my PhD work. It was from the siblings of a young man who had a bone tumour, an osteosarcoma. And I asked those siblings to just idly draw me some pictures, draw me pictures of your brother, draw me pictures of what it was like when you visited him in hospital, just draw me pictures of anything really that was important about that time, and we can talk about them. So they sat for about half an hour probably drawing lots and lots of pictures while I spoke to their mum and dad about their experiences. This was one of the ones that the younger sibling drew for me, and he was 11 at the time. They thought I was quite quirky and funny because I'd bought them pens and paper in the first place. So it kind of broke the ice, and they started speaking to me quite quickly because they thought, who is this strange lady who comes in with drawing materials immediately? So we talked about this picture. I don't know if you can see. I've just had to cross out some of the names there, obviously, that he'd written above who all the different people were. But what you can see there is his brother's laying in the bed in the yellow top, and then his brother's out of the bed there. It's the same person out of the bed. And I was able to say to him, well, can you tell me a bit more about this picture? Where is it? And he said, this is on the ward, the oncology ward. And I said, why is the bed so big? It's huge. And he explained to me those were the cot sides on the side there. It's actually quite well drawn if you look at this well, and how they were a real barrier. And that when his brother was in the bed, they couldn't reach him. He was closed off to them. They weren't really supposed to sit on the bed. They'd get told off by the nurses if they were found sitting on the bed, even though they wanted to be close to their brother. And it was very starchy and difficult to get close to him. It wasn't like the beds at home where they could cuddle at all. And they could only really get close to him when he came out of that bed, when he was off all the lines, and then he could be their brother again. So we talked quite a bit about that, about normality, about what helped for him to feel like their brother, even though he was having chemotherapy, what made it more difficult. And it really kind of broke the ice, this starting to draw and think about what was important for them, so that they could help me to understand those experiences better. So hopefully that's a good little example of how that worked within that particular project. You'll see here I've just been bringing you some literature. Many of you may remember Jane Code did some of this work. I think it was in Coventry, where again she was told you won't be able to do this. Children who are young won't be able to help inform how a hospital is built or how a children's ward looks. Obviously she proved them wrong, and this study was very similar in New Zealand, where they looked at what the children wanted for the new wards and areas they were building. And you'll see from these images here, they wanted lower reception desks so that staff weren't really high above them and towering over them and seeming all powerful and knowing that actually if they could be a bit lower, that might be a bit easy for them to talk to them. And they really wanted colourful environments and uniforms, and that's what two of the images there show as well. This was really similar. I was fortunate before I went into education actually to spend some time in Malawi as a nurse educator. And I did ask the nurses there what would improve their working days, what would improve their lives, what could I do, what could I bring while I was there? And they said to me, the children's wards, when we see pictures of them or videos of them in the West, are really colourful and beautiful, and we want that here. And I was really surprised by this. I think it would have been 2007. I thought, I was expecting you to say more staff, more drugs, lots of things. But actually, what they really wanted above all that was an environment where it didn't feel depressing to come to work, where they actually felt a bit uplifted and like they were doing something important and those children mattered. So I actually spent a large proportion of my time painting when I was there, and trying to improve that environment for them. And they did really appreciate that and say that it had made a difference. And we did do some painting with the children as well, to get them to decorate the ward area so that it felt like theirs rather than a very clinical space, which we know isn't very conducive to children having treatment and care and feeling at home and comfortable in those environments. So what are some of the other methods I used then? They were not all arts-based. Well, they were not all visual, should I say. I also used my poetry knowledge. And again, I was poo-pooed. People said, you're not going to be able to do this. It's going to be too complicated. There were moments when I thought, it is too complicated. Why have I set on for this task? But we have managed to publish a paper about this now, only just last year. And I used 3 different methods of poetry with refugee and asylum seeker families in my study. The first one was asking them if they had wrote or would like to write poems for me about their experiences in children's palliative care. And actually, one of the families did have a poem. They had a poem, they had a video, and it was a memorial poem, actually, which apparently is fairly common in Muslim communities to have a poem that's sung and to remember the person that's died. So they had a poem about their son that had died. It was in Arabic, and they painstakingly interpreted it for me. They got a family friend to interpret it. We ended up with about 4 different versions, I think. And we had a second interview where we went through some of those different interpretations of the wording, what they meant in English, how they were different to the Arabic, what was the purpose of perhaps some of the rhymes that were there in Arabic but not in English. And it was a real source of extra knowledge for me. The poem was all about their Muslim faith, and it helped me to kind of understand some aspects that I probably never would have grasped at all without this extra lens to see it through. The family were very giving and very forthcoming when it came to an interview, but some of this real depth that I uncovered through the poem they'd written and interpreting that together really gave me some additional insights. And I'll just give you a little example of that. Within the poem, there was a line which was about humiliation before God. And I thought, oh gosh, humiliation, that's a huge word. Is that the right word? And so I went to the dad and said, I just want to check this word with you because I'm wondering if it's been interpreted wrong. Maybe it's not humiliation you meant there. And he said, it is definitely humiliation we meant there. And I'll explain why. And he went on to talk to me about their families and their son's Muslim faith and how humiliation related to pain and the child's experience of pain, and how he sort of humbled himself and humiliated himself in front of God to bear the pain that they felt was from God because he knew he would receive reward in the afterlife. And it was a real privileged position to be in, to be able to hear, understand, and kind of question to develop that understanding a bit more of what that meant and how that maybe influenced some of the healthcare decision making they had. For example, the young man in question didn't want to have pain relief, and the nurse I spoke to in relation to his care said it was actually quite difficult because he wouldn't always want his morphine, and we had to have lots of conversations about that. And the main reason for that was because it made him sleepy and then he couldn't pray. So I think through that poem, through that interrogation of some of those words, it helped me to kind of understand that for this family, their faith was actual life and breath. They were living that faith every single day through every single action that they had. It was not an add-on. It was not a nice extra thing. It was absolutely the bare bones of who they were. And so when people weren't giving them the space to pray and were interrupting their prayer time, charging in with drugs, and meaning that mum had to pray in the bathroom and near to the toilet, which obviously is very disrespectful, it really helped me to understand how that kind of impacted that relationship with the nurses that were looking after her son, because obviously that respect was not there for them, sadly, in those times when they really felt that desperate need to pray for their son because he was so unwell. So that was one method. You can imagine not everybody has already written a poem or feels capable of writing a poem. So the other method in the middle there of this poster is about collaborative poetry writing, and that's where I would help people. I should say that this article was written with a colleague, well, a few colleagues, but one particular colleague who's done quite a lot of work about endometriosis. And she did a lot of collaborative poetry writing as well with a charity and a support group. And so the nature of this is that you may write poems alongside people. So it may be that you do an interview first and then you take that transcript and maybe you look at it together and say, what were you talking about there? What were some of the key words that you used or key experiences that you want to bring into this poem, and help them to write something together. So again, that can be a real interpretive space. It can be a real time of learning from each other. And also it can be really empowering. And my colleague Laura there really found that, particularly for the women in that group, they were able to feel like they really had a voice and could alleviate some of the stigma surrounding women's health issues. For me, I was able to use some of those advisory groups I mentioned earlier. I had a wonderful hospice that had some bereaved parent champions in it, and they were able to take some of the transcripts from my research study with parents and develop them into poems that we could then send back to those parents and say, does this accurately reflect your experience? What was interesting there is obviously some of them came back and said, no, or I didn't like that word you used there, or that's not quite what I meant. So again, it just added an extra layer of interpretation where I was able to say, I really think I did understand this family at the end of this research, because we had so many different points where I would touch with them and say, is this right? Is this right? Can I check? And poetry, again, was a really good way of doing that. And then the last way is with advisory groups solely. So this was where the young people's group came in, and I'm hopeful I'm going to be able to show you a video. Hopefully this is going to work. So we'll see if the technology is on my side. But I have actually got a poem of two of the young people who wrote a poem based on a child's experience, their interpretation of health-related conditions themselves through having experienced them. And the way that they wrote a poem then about this person within my research study. So fingers and toes crossed, everybody, that this technology works now and that I am able to click on this.
I come from far.
Can you hear this?
I came to England 16 years ago. My country had real problems around diversity, equality issues, and human rights. So I didn't like it. Before England, I've never had any contact or friendships with people who are different to me, but I was very open and curious. In my job, I have that mutual learning relationship. It's sort of to and from. To families and from families, but also in between. Families have come through so many different experiences outside the diagnosis of a child's health. Some are sort of small, some are bigger. Family means so many different things to different people. It's about the significant people, not who's tied together by DNA.
Hospice care is very different to stereotypes, often chaotic. So many people, not just pre and post bereavement care. You get to know the bigger picture, their story, to give the best patient-centered care. I want to learn from the families, not force our way of life upon them. I want to give people empathy. I want to show understanding through empathetic listening. Learn from the family.
We need to be holistic. We need to not just touch the surface but reach the core. It's a much wider spectrum. Trauma, loss, complex needs. It's challenging. Inaccessible communication, no interpreters. Families cannot speak the language, cannot read, cannot write. But we form new communication, like sharing food, speaking, learning, bonding through food. We can build that togetherness, but it's difficult. There was a vulnerable woman with this little baby. December, and she had no heating. It was the right thing to do, to offer to the room, the help. She was able to be the mum because we've got nurses 24 hours. But were we taking that room away from someone though?
Two cases so similar. No one listened, no one heard. No one gave their time, shouting, screaming. Mum got louder and louder. We communicated very slowly, with little steps. We started to understand her behaviour. She was scared. She was angry. She didn't understand. No one heard the international call for help. There was a lack of understanding. She was quickly judged. Mum's expression of grief was very different. Mum's grief took a different shape. Another family labelled as aggressive, labelled as non-engaging.
Lack of cultural competence from staff. No courage to help. No one gave the benefit of the doubt to the families. Assumptions after assumptions after assumptions, stuck in the cycle. Only eroded when time, resources, and effort were invested. Doesn't always mean that it's a speedy process. It's rarely a speedy process. The week we cared for over 70 members of a travelling family. I must have worked about 150 hours, but it was worth it. To enable families to be together and here.
Thank you for your support, and thank you are not racist.
So sorry, apologies from me there, just to say that these duo did write more than one poem, and I was thinking it was a different one. That was actually the experience of someone who worked at the hospice trying to explain some of the cases she'd seen. You'll see there's a website link. I think these slides will be made available afterwards, and obviously they'll be on the website as well. But there is some other examples on there as well. Sorry, I'll just move her on before she starts again. This is one of them. This is a family where you'll see here, this is one of the ways that that helped us to write these poems, just using some keywords here about what actually was happening for each of these different people. And then pulling them into different perspectives. This was a bereaved dad actually who wrote this poem, and he tried to give the perspective of the nurse and then the perspective of the family alongside that. So I won't read this whole thing out here, but you can probably see just by the word in there of patience and patience that there were some real differences between how the families cared for their children and how the staff tried to care for them as well. And that one of the big things families talked to me about was a bit of a lack of caring concern, to be honest, and that often staff were very regulated by kind of process tasks, and they weren't always thinking about how those were received. The mum in this family actually said to me, I don't speak English, I can't always tell what people are saying, but I can tell when they care because I can see from their eyes exactly how they feel about me and my family. So I think it's one of those wake-up calls to all of us that actually we can be very focused on competence and wanting to be very competent for families, which obviously is very, very important. But actually for the families in question, particularly when palliative care comes into play, it was actually more important to them to feel cared for and to feel that their needs were being respected and time was being given to them. So I'll move on from that one and talk to you a little bit now about nurse education. So I've been lecturing for the last 15 years in the West Midlands and then more recently in Exeter and Plymouth. And what I found is that some things are harder to teach than others. And apologies to anyone who thinks I'm trying to teach them to suck eggs. I definitely am not. But I do think that there are certain elements in nurse education that are more difficult to teach than others. Some science related, maths related, you either get it right or wrong, don't you really? Other things, I think, can be very experiential. So the philosophical, the ethical, the cultural, the real person or family-centered aspects can be really difficult to teach. And I really like this infographic. It comes from a research paper, which I think is in my reference list at the end. This idea that caring is an art form. And I think many of you will know that Florence Nightingale really kind of started with this ethos of that we are creating art for another person. And you'll see here all the different ways in which nurses actually do that, which some of you may have not seen this before. But I think you'll agree that actually as nurses, we are expressive, we are communal. You know, we do offer this space where we try to bring people into it and bring them along with us and try to sort of share and understand meaning in that space. It is interpretive. We do have to try and observe and also perform assessments and analysis to try and understand what's happening for another person. They can't always tell us, particularly if they're very, very little. And it is quite subjective, as you saw in that poem. You know, we do have to have an awareness of self and how we project and what we give to our patients and what they see of us. It's also really evocative, isn't it? There is a lot of feeling, a lot of sensing. I don't know how many times people have said to me in my career, I just know something's not right with that child. And you think, okay, we're going to trust that, because there is a real intuition, I think, particularly in children's nursing, where you do just get a real sense something's not right here. I can't put my finger on it. And I myself have had that before with sepsis, actually, where I've looked at a child and thought, something's not right with you. You look very green to me. The parents haven't seen it, but there's just something in you that knows this is the start. And luckily with that child, we were able to start antibiotics even before some of the clinical signs were there. And it was sort of only confirmed later that that's what was happening. So then, why use creative pedagogy? How does that help us then with some of these difficult issues? I think painting, poetry, prose can really help to challenge our students. I think it can help them to improve observation and communication, and we've seen that a lot with the medical humanities and some of the findings from their projects, but also, as I've said previously, with empathy and understanding and this openness to otherness. You know, just because someone is different, that isn't something to make us shut down. That shouldn't be something that makes us go, I can't deal with this, it's too hard. It should be a case of us going, oh, I'd never thought about it like that, or oh, that's interesting how that family lives. Can I find out about that and understand that more? And I think by students looking at artwork and learning about particularly patient related art, it can really help them to kind of confront ideas and injustices in the past. The module that I created, the Art and History of Nursing at Exeter, which is still going strong, I'm very happy to say, we looked at really difficult things like racism, and students, I think, found it more easier to debate some of those issues when they could move the conversation into the arts piece. They could say, I think that artist was talking about this, or maybe the artist was feeling this, instead of saying, I think, or I'm not sure. And it really helped them to kind of put some of these feelings onto the art, but actually have a discussion about it where they could learn without feeling intimidated, like they were going to be judged, like they were going to make a mistake or say the wrong thing. And you'll see from some of the artwork, I think, how that kind of shaped people's perspectives. We were shortlisted for a Student Nursing Times Award for this module, and this is some of the student feedback. You'll see here, this is one of our students, Harry, who's now qualified, talking to one of the artists who was a psychiatrist, and he was talking to the students about wellness through his art. And so the students seemed to really learn quite differently on the module, because we were using art, we were using poetry to try and explore some of these difficult topics. You'll see here that the students are saying that they, you know, that it impacted their observational skills and their emotional intelligence, that it gave them a better understanding of some of these topics like palliative care, and that they really enjoyed that peer support and diversity that they got from the lectures, and obviously thinking about things through the patient's perspective rather than through the textbook or through the theory alone. This is a poem that was actually written for that Student Nursing Times interview that we went to. And you'll see here, this was one of the students who wrote it. And she says, Marie's module helped us to look much more closely, to centre on patient need, understanding, and then focus. We looked individually, we looked as a collective. Clinical partners and patients gave us their perspective. We explored nursing history, prejudice, suppression, engaging our community. Embracing spirituality with chaplain leaders, the sensory elements of pain with those in need of healing. Palliative care was seen side by side with the dying, a hospice directing, kindly guiding. Each student was tasked with creating an artwork, one which would showcase their shifting frameworks. Those who attended the exhibitions we aired showered their praise, loving the powerful, thoughtful messages displayed. Through our individual talents, creativity and experience, we have taught, we have inspired, we have flourished and bloomed. Nursing is an art form. We used art to learn, to see the patient fully, holistically, compassionately, understanding their lives in all their rich tapestry. So I think that's a really nice way that she kind of summed up some of that learning, and you'll see from that poem that they actually had to create an artwork for an exhibition at the end of the module. And I have got a little case study here of Kirsty. This is her beautiful painting. It's an acrylic painting. It's quite large, about A3, I think, and you'll see on the pictures there of her painting it in the art studio that we used. And this was all about her experience on a hospice placement. And you'll see here, this is the patient she cared for, a lady who loved riding her horse, and felt very spiritual and connected to her spirituality when she was in nature. And that real restriction of being hooked up to wires and chemo that you'll see is the sort of darker side of the picture on the left. We had patients and members of the community. It was a public art exhibition, so we had about 92 people, I think, attend the first year, and we've had 2 other years subsequently. And you'll see here some of these comments from people who came to the exhibition. They came, the students stood by their artworks, they questioned the students questioned them, and they really learned from that. Kirsty's been working with us now, and kind of advocating and teaching as well, and she's just got her first clinical nurse specialist job, so we're incredibly proud of all the work she's been doing as well. You'll see that some of this work has developed into a research project, which myself and Caitlin Kike, a colleague, have been running. Actually, it was started with hospice care staff in Devon, and they told us how burnt out they were. And so we worked with their clinical teams to create some retreats. So we do about 4 retreats a year for them now, and we're trying to create a compassionate, creative clinical supervision model with them. You'll see here from this slide, there's some nice quotes and some pictures from the retreat. We're very fortunate to have a very nice area to go and do these art space retreats with clinical staff working in palliative care. But you'll see here the kind of value of them getting to spend time doing artwork, and processing some of the things that they've dealt with clinically has been really valuable for them. I really like this quote here where it says it's been a grounding, a restorative experience, and they found ways to use these skills with their patients as well, particularly those patients who were suffering from psychological stress. So you'll see here our website, which you can have a little look on there. There are a range of approaches. You can download them. Feel free to use them with your students, with your staff, with your patients and families. But please do send us feedback and do get in touch if they've been useful to you, or if you think, actually, where is this? Why, Marie, have you not got that on there? And we can think about doing that. And obviously, if any of you would like us to arrange an away day for you or your staff, provide some of these techniques and teach you more, then we can do that as well. So do get in touch with us via the website. So I'm coming to the end because I'm very aware that we need a bit of time for questions probably. At the moment, I am trying desperately to finish off an art and history module paper, the evaluation of that, to show people what we've done and hopefully help them to do a similar thing in their nurse education practice. I'm very excited because I've just been offered a place to study art psychotherapy in September at the University of Hearts. So I'm hoping to combine my nursing practice with art psychotherapy and also some of the research that I've been doing in that area as well. Rutledge really want me to write a book about health humanities, a how-to book. So let me know if you think that would be helpful to you and what I need to include in that. Our Creative Toolkits research project continues, as I've mentioned. I've put my email address there, that's my Exeter one. So do get in touch if there's any way I can help you or get you to think again. The other thing I haven't mentioned here is we are also starting arts-based practice, little group of individuals who meet about once a month online to discuss our work, whether that's your individual art that you're drawing, painting, writing, or whether it's the stuff you're doing clinically in education or research. So if you did want to join our little community again, do send me an email. You'd be very welcome to join us. So I will stop sharing there, Jean, to see if anybody's got any questions for us.
Wow, that was fantastic. Thank you, Marie. I have invited the people on the call, our colleagues, to either raise their hands if they want to speak to you and ask you questions, or to post comments in the chat. There isn't anything just at the moment, but oh yes, there is. Izzy, well done. Would you like to speak, or do you want us to speak for you? Please just let us know. If you want to put your microphone on, please do, Izzy.
Oh, maybe Izzy's a bit shy.
Okay.
I think
So you can see
Izzy's
what it
mentioned.
says,
I
yes.
can, yeah, thank you. Sorry, she's saying she's not somewhere
Yeah, it's
quiet.
okay.
So
Yeah.
I'll just read that out. Izzy's a first year nursing student in children and young people's nursing at East Anglia Uni. She's got her first shift on placement tomorrow. Oh, that's really
Oh,
exciting, Izzy. I hope that goes really well. I think when
absolutely.
your question is about implementing some of these approaches, I think often it's something very simple you can do. It's getting materials for someone. So maybe you've got a child who's being admitted for a surgical procedure, for example. I don't know where your placement actually is. But it may be that you just provide some art space materials and then you go back later and say, look at what the child's been drawing. And maybe you think about what some of those things are. So you might ask some interpreting questions of them. You might say, oh, that's a very pink tree. Why is it pink? So just use some of that curiosity that I know you will have in you and wanting to understand young people's perspectives to find out a bit more about what they're doing, why they're doing it. It may be that she tells you pink's her favourite colour and it just helps you to get to know the child a bit better. And it may just be as simple as that. So while some of the things I've done sound a bit complicated, I think actually we can all do little easy things. And similarly with families, you may say to them, actually, do you do any art space things? We had, I did some neonatal palliative care research and we had a family member there who was in the neonatal intensive care unit. They were Turkish and the staff nurse managed to use Google Translate, which we don't advocate for with big medical things, but actually this was just trying to chat to the family. And realised that this mum was a seamstress. So she was able to actually help bring some materials in so she could sew a blanket while she sat by that incubator for her baby. And she was able to create incubator cards, I'm going out of my incubator today, or I've had my first nappy change, or, and translate those. They weren't perfect, probably not as great as if you'd have actually had an interpreter there to help you, but the mum really appreciated that extra mile. So I think my advice to you, Izzy, would just be think about what little things you can do to maybe enhance that experience, particularly if as I mentioned, there is a bit of difference or slight communication issues where you think, actually, this child or this family are really, really anxious. Is there anything I can do? Maybe mum really likes crochet, and sometimes it's as simple as just being very observant and saying to someone, I really like your scarf. And then you may find out that they've knitted that themselves and they don't realise they can knit in hospital and that might relieve some stress. So think about the easy things. The complicated things will come later.
Well, yes,
Thank you, Izzy. She says that sounds brilliant. Yeah.
Excellent. Please do, and please make it routine. I wanted to comment too, please, Marie. With I'm an educationalist too, and with the students, I've always been keen to point them when we've been doing one of the modules on leading complex care for children.
Yes.
To Pearl Kingsley's poem, she wrote it quite a while ago, Welcome to Holland. And it was about her expectation of having a baby. And the baby had some differences when it was born, and she just, I would love people to read the poem and not to spoil what the poem is, but it expressed in a way I think only a mother could all those emotions that she was going through. And in clinical work, I would also like to say there are charities that come in, for example, the clown doctors, and they're performing with banjos and get people to join in a little bit of joy in the daily life. And sometimes people you work with are a bit skeptical about bringing this in. They might think it's not serious, it's too frivolous, but it isn't. So could you please expand on what I'm saying, Marie, please?
Yeah, I think you're really right, Jean. I think it is about those little things, isn't it? It's the little interactions. It's the just trying to bring in a child-centered approach where it's sorry, I'll just stop sharing now. I realize it's still sharing. Where it's about children. Children like color, they like noise, they like toys. I think they are very intrinsically arts focused. They are very keen to use arts materials if you give them to make a mess. So I think thinking about ways in which you can do them. I did an elective in Australia during my nurse training, which was really great. And one of the nurses there was so good at just using the equipment that was there. She would, they had a lot of Indigenous families that would often come, they were quite neglected. There was quite a few issues. And she had this lovely way of, if a little one needed a wash, for example, she'd bring a bowl out with warm water and she'd use the oxygen to make bubbles and create this kind of environment where the kids were, thinking they were having a spa treatment, I think. But she just had a way of making the ordinary extraordinary. And I think that's something that as children's nurses, we should be trying to do. And I think it also opens that up to parents who perhaps feel very restricted in the hospital environment in particular, where they think we can't read to them, or we can't use felt tips because it's going to get on a tray that might need to be used for something or another. So I think it's about just trying to do those things. And I certainly think with the work we've done with staff, recognizing that a lot of people have resistance to these approaches because they've had bad experiences. So there's a real body of evidence now that suggests if you had a bad experience at school with your art teacher being very judgmental or telling you you're not very good at art, which is what I had, it can take a long time for people to get over that, where they feel like they're being judged for their art, they feel like they have to be good. And it's definitely not about being good, it's about process. For the students, it's a process of learning and experimenting and debating. I think for children and families, I think it's about expression. It's definitely not about the end piece. It's not about creating a Van Gogh. It's not about exhibiting in a gallery. It's about, what does that process give you? Does it give you time? Does it just give you a mindful activity to take your mind off the fact you've got to wait for your child to come out of surgery? So I think for us as staff, it's thinking about what does the process of art making give, and that's actually much more important than the end result, which may just be a scribble. It may be nothing, but it's what does it give during that time that someone has chance to create something.
Colin has put, yes, Colin has asked a question and he's saying students get excited. Do you want to tell us a bit more, Colin? We have got a couple of minutes.
Yeah, so I work at UE down in Bristol, and we kind of try when we can to kind of get them colouring, get them drawing as student nurses, because again, my mindset is if they can do it in the classroom, they can do it hopefully in the placement areas as well. We've got a session coming up actually this week where they're going to storyboard their presentation for their child that they're going to present for their complex needs module.
Nice.
So they're going to storyboard it hopefully, and then helps them get their message across then for what they're going to then write in their assignment. So so we try again. Another member of our staff is quite creative. She wants to use it whenever she can. So we try and do it when we can. We also use picture books a lot with our student nurses.
Nice.
Around sort of death and dying. So we've got quite a few death and dying picture books that we talk through. So we use a few different methods, and the students do, I think like you said, Marie, when it's not sat in a classroom looking at a PowerPoint, they are quite interested.
Yeah.
So
it's just different ways, isn't it? I'm
exactly.
going to put Colin, I'm going to just put the Creative Toolkits and my email address website on here, just in case they're useful to you. On the Creative Toolkits website, there's lots of downloadables. So if you've got students who go, oh, I'd love to write a poem actually, or I'd like to do more with this, then it may be that those resources they can download, and it gives them sort of a few instructions of how to start. Because I think the other thing with some of these approaches is people are keen, but they sort of are a bit, they're a bit restricted, thinking, I don't know where to start, you know. So I hope it's useful. Please do direct them to it if it is of any use to people. We are adding to it all the time, and it's got some of our research on there as well, if some of the students are a bit reluctant and they want evidence of why they should be doing this as well.
That's great, thank you. And also, like you said, their stumbling block is I can't draw. But like you said, it doesn't matter what the end product is. It's just getting them to draw. So we do something with what is a children's nurse, what makes a good children's nurse, and they'll draw, you know, different things on that children's nurse's uniform, you know. So it's just, I think my mindset is we're trying to get them into the mindset of not children. It doesn't sound right to say make them the mindset of children, but getting them thinking like the children and how they can come across. So yeah, no, I quite enjoy it when I see on my time plan that I've got a colouring session coming up. I'm like, yes. So yeah, no, we really enjoy doing it down in our university. But yeah, thank you for that link to the Creative Toolkit.
Oh, thanks,
Wonderful.
Colin. I think the other thing is just trying to get people to experiment. I really do think that's so important. I mean, at hospice care, we had a member of, I think she was one of the healthcare assistants, and she said at the end of a retreat we did where she'd been feverishly trying all these different approaches, collaging, painting, all sorts of things. And she said, I've always bought things for my daughter, but just assumed it's all for children, really. And she said, doing this now, having this day where I've been able to experiment, she said, I realise this is the first day in probably about 25 years I've not felt anxious. And I thought, oh my goodness, you know, to actually have that experience where she was quite tearful, really, that it just had such an impact on her because she hadn't realised that it was something she could use. She just assumed it was for children, and just, I think, to encourage people to have a go. The other thing with the creative toolkits is we wanted something diverse because some people will really lean towards word-based things. Other people will really like the visual or maybe the needlecraft type craft, you know. And so I think we've tried to have a bit of everything, acknowledging that for some people, you know, actually sewing is really, really helpful to them, but for others they'd be much more comfortable writing and find a lot more solace in that. So I think the other thing to say is if you don't find what helps you, then there will be something, so keep trying. It's just maybe you haven't found the right thing yet.
Excellent. And I don't know if there's anybody else wants to say anything else in the very last moments that we've got, but Marie, this has been absolutely brilliant, and I'm sure it's been appreciated by everybody that's on the call. You've left your details. We really appreciate that. So do come back and tell us maybe what you're doing on this wonderful, exciting course that you're doing, Marie.
Yeah, I'm really excited about that. So I will definitely. I'm hoping I can still do it in a child centered environment. So yeah, that's my plan.
Thank you so much. So all the thanks are just coming in now. So I'll just stop the recording.
Thank you so much, everyone, for listening and your time. And if anybody has got any questions that they'd be more comfortable emailing me, do go ahead.